So let's move deeper and deeper into the actual diagnoses now, and we'll start by talking about the neurodevelopmental disorder. They do not call it mental retardation anymore because of the stigma that became connected with that. But you do need to include a specifier in terms of the severity. To summarize the intellectual disability, know that there needs to be deficits both in the intellectual and adaptive functioning domains. IQ tends to be below 70, though I think there's some leniency in the DSM-5 depending on the level of functioning. And the onset is during the developmental period. There are 4 degrees of severity that are specified, and they also say what domain, so conceptual, social, and practical. What's the key? Here's the key and to remember. You need deficits in 2 core domains. So when you think autism, think deficits in 2 core domains. And those 2 domains are the social and the repetitive. And now what are the 3 levels? So this is another thing that's important to remember about autism. There's requiring support, substantial, and very substantial. So 3 different levels. So first, let's just say the basic summary of autism. How many diagnostic criteria sets are there? There are 2. What are they? Social and repetitive in terms of patterns of behavior, and there must be impairment. This is neurodevelopmental, so it must be early onset, early developmental period. Usually you can see by 12 months. There are often intellectual impairments, language abnormalities, uneven profile of cognitive abilities to go with, and 3 levels of care: support, substantial, and very substantial. So we're going to talk about the best treatment as well. And just to summarize, educational and vocational interventions are helpful. In particular, TEACH, which is directed specifically, will help with the communication, social, and coping skills. For adolescents and adults, vocational training and placement can be helpful. We also have behavioral interventions, and that's expected. Applied behavior analysis and pivotal response training are the 2 main ones. Applied behavior analysis kind of tries to reduce the self-injurious and other behaviors like that and promote desirable ones. It incorporates a functional behavioral assessment. Pivotal response is an application of it, and it's supposed to really target motivation and responsivity. Psychotherapy can be helpful, but in particular directive types to treat the comorbid conditions like depression and OCD that might come along and help with social skills. Given that there's often a lot of support needed, it's really important to include the parent and family and refer to community services. And finally, medication is not really effective for the core symptoms of autism, but it can be useful for treating depression, anxiety, and other symptoms that might be contributing to distress. Here's some requirements, the diagnostic criteria. The onset is prior to age 12. There need to be 6 symptoms of either inattention and or hyperactivity, and it needs to be present in 2 settings. Those are the 3 essential things: 6 symptoms, onset prior to 12, present in 2 settings. So you can look here to see the revisions specifically, and the criteria are in red from the DSM-4 to the DSM-5. To quickly summarize ADHD, know that A, it is a persistent pattern of inattention and hyperactivity. It must have been present before the age of 12. This is neurodevelopmental, though a lot of people are diagnosed as adults. So for kids, you need to have 6 symptoms plus in one of the categories. And for adults, it's just 5. This also needs to be present in 2 settings and interfere with functioning. So remember, with kids, you need to see 6 symptoms at 6 months or more. Adults, 5 symptoms. They tend to score lower on IQ tests even though they have above average intelligence, and struggle academically and socially. What are interventions? A lot of behavioral interventions and social skills training. Neurofeedback's been found to be helpful, and psychostimulants are probably necessary to really treat it. Therapy alone has not proven to be very effective. So what is a learning disorder? There's 3 subtypes in reading, writing, and arithmetic. Pretty easy to remember, reading, written, mathematics. And it is marked by difficulties related to academic skills, as indicated by the presence of at least one symptom that lasts for at least 6 months despite provision of appropriate interventions. Usually you will see that on a particular area, the patient lies 1.5 standard deviations below the mean. Specific learning disorders. So what to know about specific learning disorders? It's been changed and it's coded with different specifiers. Tourette's disorder is the one that we've all heard of, and here's the criteria. 1 vocal tic and multiple motor tics, needs to have lasted more than a year and began prior to 18. This tends to decline over time, but to treat it, antipsychotics like haloperidol are helpful in 80% of cases. You can give a provisional diagnosis of less than a year. Comprehensive behavioral therapy has been also shown, or treatment has been shown to be effective, and that includes habit reversal, relaxation, and psychoed. So to summarize Tourette's, the criteria for full Tourette's is 1 or more vocal tics, and you have to have multiple motor tics. These need to be present and persist for over 1 year, and the onset, this is a neurodevelopmental, so the onset's before 18. You can specify if it's persistent for a year, or if it's been less than a year, you can make a provisional diagnosis. Alternatively, there are diagnoses available for just vocal tics, etc. The best treatment is actually pharmacotherapy for Tourette's, the antipsychotic haloperidol. You also comprehensive behavioral treatment like habit reversal, relaxation training, and psychoeducation can all be helpful as well. So we're moving into the section on schizophrenia and other psychotic disorders. So we'll start with delusional disorder. Big change from the DSM-5 is that it does not have to have anything bizarre at this point. But let's talk about what a delusion actually is. It's a false belief that is firmly held despite what everyone else believes or existence to the contrary. So this is important to know the difference between delusion and delirium. You need to have 1 or more delusions for at least a month. Functioning cannot be too impaired. It's just there's maybe some functioning problems as a result, but of the delusion itself. And there are 5 different types. Brief overview of schizophrenia. There are active phase symptoms, and you need to have at least 2, a delusion, hallucination, or disorganized speech of those. The duration onset, at least 1 month of active phase symptoms need to happen, and there needs to be continuous signs of it for 6 months or more. The onset is typically late teens to early 30s and peaks in mid-20s for males and late 20s for females. You can specify with schizophrenia whether what's showing up in terms of the active phase, delusions, hallucinations, disorganized speech. And then the best treatments, quick overview, is family psychoed, cognitive behavioral therapy, social skills training, supported employment, social learning, cognitive remediation, and then other ones include relapse prevention, family therapy aimed at reducing negative expressed emotions, helping with medication management. What about the etiology, treatment, and course? So this has been very much linked to genetics, and one theory is that there's an elevated oversensitive response to dopamine. In terms of neurotransmitters, serotonin, glutamate, and GABA have recently been implicated. These are different in terms of the positive and negative symptoms. Treatment often includes antipsychotics, almost always. Therapy can be CBT, social skills, and family therapy can be helpful here. And what about the statistics on schizophrenia? Well, we know this is a genetically linked disorder, and you'll find that with bio siblings and fraternal twins, it's about 1 in 10, 10 and 17%. For identical twins, it's now 1 in 2, so about 50%. And for both parents, it's also about 50%. There are different schizophrenia spectrum disorders, but one thing to remember also about schizophrenia before we move on is that the prognosis is worse if there's a long prodromal phase, and better with late onset, good premorbid functioning. Women with insight and no family tend to do better. I don't know about the no family, but women and insight. Major depression with psychotic features has to be distinguished, and here's the difference. With schizoaffective disorder, which we'll talk maybe not more about, there has to be 2 weeks where the patient doesn't exhibit mood signs but has psychotic symptoms. That's the difference. Now we're moving into the bipolar and related disorders. Bipolar 1 is sort of the most serious of the two, and you don't actually have to have had a depressive episode ever. All you need is one manic client for 1 week, most of the day, nearly every day. And then there's three symptoms from the list. So what about bipolar 1 disorder? The diagnostic criteria here is that there needs to have been, and this is the only thing essential for the diagnosis, one manic episode for 1 week, or, maybe they were hospitalized before they reached 7 days, and that counts too. Symptoms need to be most of the day, nearly every day, and 3+ symptoms on the list. It either leads to hospitalization or very serious impairment. The specifiers here, you can say whether there's the self-esteem, inflated esteem, sleep, speech, ideas, distractibility, goal-directed activities, psychomotor agitation, or excessive involvement in pleasurable activities. So what are the best treatments for bipolar? Here's the quick overview before we go a little deeper into it. Psychoeducation and cognitive therapy, as well as behavioral interventions that help with impulse control, like behavioral reversal, role reversal. So those are important. The referrals and adjuncts. Psychiatrist for medication eval and treatment is essential. If there's an acute crisis, it's important that there's inpatient hospitalization for stabilization. And sometimes there are partial hospitalization programs and day treatment depending on sort of the stage. The Alliance for the Mentally Ill for Family can be helpful for families, and Social Security can also be helpful. Making the bipolar 2 disorder though, this you do have to have a major depressive episode and one hypomanic. No mania. As soon as there's mania, it's bipolar 1. And finally, there's cyclothymia. And with cyclothymia, there's fluctuating hypomanic symptoms and numerous periods of depression, but never do you meet the full criteria for either mania or major depressive episode. This has to be going on for 2 years in adults and 1 year in children and would be causing impairment. These mood issues have to be present for half the time. So when you diagnose major depressive disorder, make sure there's been no hypomania. So how do you treat major depressive disorder? The 2 primary interventions you will see are psychotherapy and pharmacotherapy. In terms of pharmacotherapy, SSRIs, TCAs, and MAOIs are your go-to drugs. SSRIs are the number 1, and that's for serotonin for moderate to severe depression. Tricyclics, the TCAs, they're more for classic depression, which means that you have more vegetative symptoms. And the MAOIs are prescribed for people who aren't responding well to the other ones, or folks who have kind of atypical symptoms. There's other antidepressants out there like Effexor and Cymbalta that are SNRIs with norepinephrine. Psychotherapy has really the literature emphasizes cognitive behavioral or interpersonal. And there are a couple other options is phototherapy, not just for major depression, but if there's a seasonal pattern to it. And finally, electroconvulsive therapy is still used, and it's used rarely though, but for those who have very severe endogenous depressions that just have not responded, it can actually be very helpful and save lives, really. So what interventions? So those are the overview of the interventions, but when you do cognitive behavioral, its focus is on problem solving, self-management, self-control. Acceptance and commitment therapy is one version, emotion-focused is another. And for older adults, you might use reminiscence or life review instead. And you want to, similar to bipolar 1, make a psychiatric referral, especially for moderate to severe, mild depression, probably no meds. And then if there's acute crisis and suicidality, then you want to do inpatient. Sometimes you'll have partial hospitalization programs as well. And with persistent depressive disorder, just remember the 1 year for kids and 2 years for adults. Moving into the anxiety and then now separate obsessive compulsive disorders, trauma, stress. So what is separation anxiety? Separation anxiety is a developmentally inappropriate anxiety of being away from an attachment figure. You need to have 3 or more symptoms from the list involving distress around separation, fear of being alone, physical symptoms that emerge, and with kids there's often school refusal. Now separation anxiety can also be a diagnosis for adults. It's important though that with kids it's only a month is needed, whereas adults 6 months are needed. The onset is after toddler and infant years, of course, where it's very normal to have that kind of distress. So 4 weeks for kids, 6 months for adults. For adults, the attachment figure could be a partner. It could even be their own child. So with specific phobia, this often develops after a traumatic event, not necessarily, maybe not even often. It typically lasts about 6 months or more. Treatment is exposure with response prevention, the best being if it's in vivo. The lifetime prevalence is 9 to 12%, and every time they're exposed, they might have a panic attack. 13 years is the average age of onset. So what is social anxiety disorder? It is a persistent fear of one or more social performance situations. The situation usually involves unfamiliar people and there's a fear of scrutiny. They fear that actions will result in embarrassment, and exposure to the situation provokes immediate anxiety, which is often situationally bound panic attack. So these are panic attacks that can be predicted given the feared situation. The distress has to be clinically significant for it to be a disorder. And what is the duration and onset? Can you remember? Well, it's persistent, typically 6+ months. So like generalized anxiety disorder, which is a year, you need to really have shown the symptoms for this for a very long time. I got to double check on the generalized anxiety disorder. First of all, just like with mood disorders, you have those building blocks. Panic disorder, you have the building block of a panic attack. It has been unlinked from agoraphobia. So panic disorder is now a diagnosis. The symptoms are recurrent panic attacks, which are abrupt surges of intense fear. It reaches a peak within minutes. And here's the essential diagnostic criteria. One attack needs to be followed by 1 month of concern, worried about it. So these are recurrent panic attacks and the 1 month of concern that it's going to happen again. The median onset is 20 to 24 years. You have to rule out hyperthyroidism, cardiac arrhythmia, and other medical conditions. Symptoms include, and specifiers and notes you can add are palpitation, sweating, trembling, chest pain, derealization, fear of losing control, among a few others. So how do you treat panic disorder? I'll go a little more into this, but just to summarize, you're looking at cognitive behavioral, psychoed type stuff, as well as psychiatric referrals. Agoraphobia is a fear of two or more situations. Agoraphobia is a fear of two or more situations that are public, like waiting in line, crowds. They fear escape will be difficult and that they will be embarrassed. They will avoid with a companion. They'll be a little better with a companion. There's distress, impairment. It typically lasts at least 6 months. In vivo exposure with response prevention has been shown to be helpful. Intensive is probably better than long-term. 33% of these people are restricted to home. The average age is 30 to 44. The symptoms: restless, fatigued, mind goes blank, they're irritable, they're tense, they have trouble sleeping. What to remember, that it needs to be 6 months or more. 6 months or more and constant. They must find it difficult to control and have 3 or more of the symptoms listed. The treatment is CBT or CBT and drugs, like SSRIs. Generalized anxiety disorder is a disorder you'll see frequently. The criteria is to have 3 or more symptoms from the list in the DSM, which includes both symptoms of anxiety and thinking, like difficulty concentrating, as well as physiological symptoms like fatigue and muscle tension, gastrointestinal stuff. People experience the anxiety as very hard to control, and it lasts over 6 months. So not a year, 6 months, 6 months, 6 months. The best treatments here are CBT, biofeedback and relaxation, self-monitoring. You also want to make referrals for the medical doctor and the psychiatrist. The symptoms: restless, fatigued, mind goes blank, they're irritable, they're tense, they have trouble sleeping. What to remember, that it needs to be 6 months or more. 6 months or more and constant. They must find it difficult to control and have 3 or more of the symptoms listed. The treatment is CBT or CBT and drugs, like SSRIs. Quick overview of OCD. It is characterized by obsessions and or compulsions, and it's essential that these are time-consuming and distressing, an hour or more a day, and causing impairment, or at the, even if not an hour, causing significant impairment, repetitive behaviors. The duration and onset is typically earlier age of onset in males, but it evens out as they get older. So as we're older, it's actually more common in women than men. The specifiers. So you want to specify if it's either an obsession or a compulsion. So obsessions are persistent thoughts, impulses, or images that are intrusive and they're distressing. The compulsion is a behavior or mental act that the person feels driven to perform, and that's usually to kind of reduce the anxiety caused by the obsession. So how do you treat OCD? Interventions, so exposure and response prevention. Again, with a lot of these anxiety disorders, exposure with response prevention is the tendency. Cognitive therapy, acceptance and commitment therapy. Relapse prevention. Thought stopping is one that you don't see on all of the lists. So thought stopping, since there's such intrusive thinking, thought stopping, relaxation skills, as always, and medication management. And of course, this is a pretty genetically based, endogenous disorder oftentimes. So you want to make the psychiatric and medical evaluation referrals. So what about treating body dysmorphic disorder? So you want to work with CBT, yet again, especially because we're dealing with the OCD territory. Cognitive restructuring, exposure with response prevention, behavioral experiments, mirror perceptual retraining, sometimes antidepressants, and then also working with relapse prevention. Moving into this trauma and stressor disorders. First is reactive attachment. What you need to know is that you need to have 2+ symptoms from the list. The diagnostic criteria is that you have real inhibition and withdrawal and behavior toward caregivers. The onset is between 9 months and 5 years. This is a childhood disorder. The kid does not respond to comfort, and it must be due to extremely insufficient care. Disinhibited social engagement disorder can be quite troubling to actually witness. They are inappropriate and excessively familiar with strangers. And again, this is also due to insufficient care. So what's the overview of PTSD? The exposure to the traumatic event with resulting symptoms in 4 categories. Can you name the 4 categories? They are intrusive, avoidance, negative alterations in mood and cognition, and a sense of arousal. You need to have 1 of the intrusive and avoidance and 2 of the negative alterations and arousal. The event must involve actual threatened death, serious injury, or sexual violence. And there are different criteria for kids, so you only need to have symptoms in 3 of the categories. Similar, one of intrusive and avoidance, and then 2 in arousal. So you don't have to have the negative alteration. The event may also be witnessed in person, and if with a kid, and learn that it occurred to their caregiver. The duration needs to be over a month. So that's where you're differentiating between the acute stress and the PTSD. A delayed onset is a specifier that's important to know of 6 months without full symptoms, and then there it comes. The specifiers, in addition, are whether there is accompanying depersonalization, derealization, whether there is a delayed expression, like we said, and unfortunately, the delayed expression is actually a worse prognosis. The interventions, which we will go more into, but just to sum them up: prolonged exposure, cognitive processing, seeking safety, stress inoculation, EMDR, and then, of course, the appropriate medical and psychiatric referrals. PTSD has been changed. Now sexual violence can be included. Criteria is exposure to actual or threatened death, injury, violence. We need to have 1 or more intrusion symptoms.
Here are the requirements.
And that has led to avoidance, exposure to arousal. These are
the traumatic event,
well,
which
that you have
could
to
be
be avoiding
death,
things and have
serious injury, or sexual violence. And there are different ways
1
in
to 2
which
years
that can happen. It can be directly,
is
it
typical,
can be witnessing or learning that it happened to someone close, or finally being exposed to the details repeatedly, except when it's through the media. Secondly, there needs to be presence of symptoms as a result, and at least 1 of them must be intrusion symptoms, and that would include recurrent involuntary distressing memories of the event, dissociative reactions, intense or prolonged psychological distress when reminded, and physiological reactions. Thirdly, there needs to be a persistent avoidance of stimuli that's associated with the event, and that can be evidenced by 1 or both of the following: either avoiding the memories, thoughts, feelings as internal things, or avoiding external reminders that will elicit the distressing memories, thoughts, and feelings. So first is exposure to a trauma. 2 is presence of at least 1 kind of intrusive symptom. Third is persistent avoidance of associated stimuli. And then 4th, negative changes in cognition or mood are associated with the event. And that needs to be evidenced by at least 2 of the following: inability to remember an important aspect, persistent negative beliefs about oneself and others in the world, persistent distorted cognitions related to the event's cause or consequences, markedly diminished interest in significant activities, feelings of detachment from others, and persistent inability to experience positive emotions. 6, and finally, there must be a marked change in arousal and reactivity associated with the event, as evidenced by at least 2 of the following: irritable behavior and angry outbursts, reckless or destructive behavior, hypervigilance, exaggerated startle response, impaired concentration, and sleep disturbance. So 2 of those. So 6 things: 1, exposure to the trauma; 2, presence of 1 intrusive symptom; 3, persistent avoidance of internal or external stimuli; 4, negative changes in cognition or mood; and 5, marked change in arousal levels. This is different for children under the age of 6. To quickly summarize acute distress, you're exposed to the same type of events that cause PTSD and 9 or more symptoms from any of 5 categories. The exposure types, you need to experience it, witness it, learn it occurred to someone close, or have repeated exposure to aversive details of the event. This is 3 days to 1 month. The 5 categories are the same as PTSD, and also dissociation. That's an important one to remember. The best treatment is the same as with PTSD, pretty much. Hopefully there is not as necessary of long-term treatment here. Acute stress disorder lasts 3 days to 1 month, whereas for PTSD standardly, it is anything more than a month. So as soon as you hit the month line, you're moving into PTSD category. 9 symptoms following a trauma of 5 different categories: intrusion, negative mood, dissociation, avoidance, and arousal. Adjustment disorder has to have onset from some event within 3 months and must remit within 6 months. This is an emotional or behavioral response to a stressor, and it's just not proportional to what happened. Moving into the dissociative disorders: somatic, feeding, elimination, and sleep-wake. What are the dissociative disorders? Well, you have DID, dissociative amnesia, depersonalization, derealization.
Disorders. This has changed significantly. This is a very big change because what happened is there were so many somatiform disorders that people would get confused. Well, what's the difference between hypochondriasis versus a somatiform? What's all of these different diagnoses? They make no sense. So what they did is they said, all right, let's decrease these numbers. We have to. And let's look at some of these subcategories and let's stop confusing and overlapping. Let's look at how we can make this better. So what they did is they took somatization, hypochondriasis, pain disorder, and your undifferentiated somatiform disorder. They removed that and they created new symptoms and new, a little bit tweaked names, and included some of these symptoms into it. So for example, we have our new diagnosis, which is illness anxiety disorder. So this will sound a lot like a couple other disorders that were in DSM-4. But in DSM-5, illness anxiety disorder is a preoccupation with having or acquiring a serious illness. So it is a preoccupation with having or acquiring a serious illness. There are no somatic symptoms in this one. The somatic symptoms are not present. There is a high level of anxiety about health, and the individual is easily alarmed and about their personal health status. So, for example, these people may every day wake up, naked in front of the mirror, looking at their bodies to see if there's any changes. So, is there another birthmark, or is there another something that they perceive as a birthmark come up, or is there anything that has physically changed that I need to be alarmed of? Now, there's 2 different specifiers for this. There's the people who are care seeking. So those individuals, you see a lot of hospital visits, emergency room visits. You will see a lot, they'll go to their doctors a lot. Whereas the care avoidant people, so they have this illness anxiety, but they're scared. They don't want to know, so they'll stay away from the doctor, but they're still preoccupied and anxious about the fact that they may have a specific illness. And so there's the care seeking and the care avoidant type. Now, what they did to change everything and make it really clear is they just formed a somatic symptom disorder. So you don't have to worry about you have to have 2 sexual symptoms, 1 symptom here, 2 symptoms neurological. You don't need to know any of that. What you need to just know is that a somatic symptom disorder is one or more somatic symptoms that are distressing or result in significant disruption of daily life. And so you're just looking, if they have one or more symptoms, you're looking at somatic symptoms, you're looking at a somatic symptom disorder. Now, these individuals will experience excessive thoughts, excessive feelings, excessive behaviors related to that somatic symptom. So you want to look at that as well. Now, what they did, because previously we had a pain disorder, what they did is they just attached the specifier for somatic symptom of somatic symptom disorder, and you would say with predominant pain. That is what we used to know as pain disorder. So it's now just a specifier. What else did we see change? Well, conversion disorder is different name, but the disorder is the same. So what a conversion disorder is where an individual, so say for example, somebody goes deaf because they don't want to hear that their partner, significant other is cheating on them. That's one example. There's tons of them. And so they convert a psychological issue into a physical one. And so it's the same exact thing, except it's no longer called conversion disorder. It's going to be, once ICD-10 comes out, it's going to be called functional neurological symptom disorder. Functional neurological symptom disorder. So what's familiar here, if you go back to the beginning of this lecture, I had talked about how DSM-1 was very medical model. And then we moved into more of a psychosocial model. And then it was looking at pure psychological names. And now we're moving back towards this medical terminology by saying functional neurological symptom disorder. So under somatic symptom and related disorders is also your factitious disorders. So with a factitious disorder, the person isn't doing this for monetary gain. So what happens is they have this specific disorder for the pure reason of playing the sick role. So to be getting attention around the sick role and whatnot. And so if it's a factitious disorder imposed on self, it's what they may do is they may leave chicken out for a week. And then in a week, they eat the chicken and they become sick. And so that they can maintain their sick role, okay? Not for monetary purposes. If they were doing, say, for example, you see malingering, what's called malingering. Malingering is when the individual will do things like that, but it's for monetary gain. So I'm going to leave this chicken out for a week. I'm going to make myself sick. And now I'm going to sue Ralph's and say that they provided me with spoiled chicken, which resulted in my illness. And now I'm going to sue them for money. That's malingering. Factitious is purely about playing the sick role, getting some attention from others. So that is now factitious disorder imposed on self. Now, if an individual was sick because somebody else was putting them in the sick role, so for example, a parent leaves the chicken out for a week, it's spoiled, they feed it to their child, which used to be known as Munchausen's, right? Munchausen's by proxy is now called factitious disorder imposed by another. So if you remember in the DSM-4, that was an NOS. Munchausen's was an NOS. Now it is a specific separate disorder. So factitious disorder imposed by self, they're maintaining the sick role by doing something to themselves. Factitious disorder imposed by another, they are imposing that sick role onto somebody else. So let's move into feeding and eating disorders.
Okay, so to briefly overview, pretty quickly, somatic symptom disorder, it it's when there's one or more symptoms that are causing distress and disrupting daily life. And it involves excessive thoughts, feelings, and behaviors related to the somatic symptoms. So it could be headaches, it could be nausea, and it's disruptive. But it's not hypochondria, like a preoccupation, I'm afraid I'm sick. It's more like, oh my God, I'm getting these headaches, I feel so ill. And it's persistent. So this tends to average over 6 months. And the reactions, you can specify what the particular reaction is. So like high anxiety about health, excessive time and energy devoted to health, and the predominant pain specifier is really important to remember. So there's a couple things to say in terms of interventions. According to the ATABS materials, there's not been a specific intervention that's been established as effective. However, an eclectic approach that emphasizes the alliance, psychoeducation about the disorder, and consistent reassurance has been useful for many individuals, and that's according to Yetzi in 2004. In addition, having a single physician act as the primary caregiver is beneficial. Sometimes an SSRI can reduce the symptom preoccupation and the coexisting depression and anxiety. CBT can sometimes be useful to reduce the somatic complaints and medical costs as well. So all that said, when we're talking about somatic symptom disorder with predominant pain, then there are some things that have been found specifically to be helpful, and we're going to talk a little more about that now.
Low weight, less than minimally normal. Well, that's subjective. So 4, we had non-purging type versus purging type. 4, we had non-purging type versus purging type.
Elimination disorders are enuresis and encopresis. Enuresis is voiding of urine into the bed. This needs to be, criteria is twice a week for 3 months. There are specifiers of nocturnal, diurnal, or both. You need to be at least 5 years of age because otherwise it could just be part of development. The treatment is Bellin pad, which is basically an alarm that wakes the person up, and that's found to be effective in 80% of cases. Additionally, imipramine can suppress it, but most people relapse because there hasn't actually been treatment. An antidiuretic can also be helpful for a short period of time. Encopresis is the involuntary or intentional passage of feces into inappropriate places. This has to be once a month for 3 months. So this can happen much less frequently and still be considered a disorder. Sleep-wake disorders. We will just briefly talk about of these: insomnia and narcolepsy, and also non-rapid eye movement. But insomnia disorder is it requires somebody to be dissatisfied with the quality or quantity of their sleep. This needs to be 3 nights a week for 3 months. So 3 nights a week for 3 months, which is, almost half the time you're struggling. One symptom of this, like initiating sleep, waking up too early, all of these things. Treatment incorporates strategies like sleep hygiene, education, and stimulus control. Hypersomnolence is excessive sleepiness despite sleeping enough. Narcolepsy, this is also 3 times a week for 3 months. There are like daytime naps or just lapsing into sleep accidentally. It also requires the presence of cataplexy or REM latency, which is less than 15 minutes. Finally, non-rapid eye movement disorder. This is different than nightmare disorder. The essential features is that there's an incomplete awakening during the night, and it's the first third of the sleep episode. It can involve sleepwalking, sleep terrors, but the thing about this is that there's limited or no recall of it even happening. Whereas with nightmare disorder, the dreams are very well remembered, and they're fully awake and afraid when they wake up. Now we're moving into sex, gender, impulse, conduct, substance. So what are the 3 sexual dysfunctions that you're most likely to see in your practice? The first is erectile disorder. The second is genitopelvic pain penetration disorder. And the third is premature ejaculation. So let's talk about what each of those are. Erectile disorder is a marked difficulty in obtaining an erection during sex, maintaining it, or losing it at the end. And it happens on almost all occasions, and you need to remember that it's there's a 6-month, for all of these, there's a 6-month minimum that it has to have been going on. You can say how distressing it is, how long it's been, how severe it is it a generalized or situational piece. And before you assign that, you do need to rule out medical conditions and substances, because antidepressants or multiple sclerosis, there's different things that can cause it. So medical evaluation is necessary, and you're going to want to treat it with CBT and or Viagra. Genitopelvic pain or penetration disorder is the diagnosis in the presence of persistent or recurrent difficulties in one or more of the following. It could be vaginal penetration or pain. Pain in penetration, intercourse. There's anxiety during, before. There's tension, and again, this has to be about 6 months and distressing. And there is research that shows it's associated with a history of sexual or physical abuse. Finally, premature or early ejaculation is that there's a recurrent pattern of ejaculation during sexual activity within about a minute of penetration and or before the person desires it. And again, 6 months and different same specifiers. So we're going to now talk about how these disorders can be treated. Paraphilic disorders. These are intense and persistent sexual interests that might cause harm or distress to others. That's one possibility for paraphilias.
Impulse control and conduct disorders. So this section combines these following ODD or these following disorders, such as oppositional defiant disorder or ODD, conduct disorder, disruptive behavior disorder NOS, intermittent explosive disorder, pyromania, and kleptomania. So starting off with oppositional defiant disorder, what we have in the new DSM, so DSM-5, what they've done is they've categorized 3 major sort of categories of symptoms. So for example, the person in at least 6 months, so the 6-month criteria remains the same. They have to have at least 4 symptoms, and it could be from any of the categories that I list. So the first category is angry or irritable mood. So from that category, we have often loses temper, is often touchy or easily annoyed, is often angry and resentful. Now, for the argumentative, defiant behavior category, we have often argues with authority figures, often actively defies or refuses to comply with requests from authority figures or with rules, often deliberately annoys others, often blames others for his or her mistakes or misbehavior. So that will be category 2. Now with category 3, this is vindictiveness. So with vindictiveness, the person has been spiteful or vindictive at least twice within the past 6 months. So it doesn't matter where or what category you take these symptoms from. What matters is the person has at least 4 symptoms. If they have 4 symptoms, then it's going to be categorized as ODD, or they meet the criteria for ODD. Now, what they did with specifiers, so in DSM-4, what they said is it really should be 2 or more settings, but what happened here is that they found that it would happen in one setting. So how their specifiers are for severity depend on the number of settings that this exists in. So if they have any of these within one setting, that's mild. Two settings, so say now it's home and school, moderate. Now let's say it's home, school, and maybe work. Because again, ODD can be diagnosed now in adulthood. So maybe it's in 3 or more settings, and one of those settings is at work. Then it's severe. So again, the specifiers of ODD would be mild, 1 setting, moderate, 2 settings, severe, 3 or more settings. So that is ODD. The next one that we want to take a look at is intermittent explosive disorder. Well, in DSM-4 TR, what they said is that it required physical aggression. So it required that for a diagnosis of intermittent explosive disorder, the person had to be physically aggressive. But the situation is this. Now, in DSM-5, they say it could be verbal aggression, non-destructive and non-injurious physical aggression, and it also could include destructive and injurious physical aggression. So it doesn't have to be just physical aggression. It could be just verbal aggression. So that's the big change in intermittent explosive disorder. The only other criteria is that the child must be at least 6 years of age. Now let's look at conduct disorder. So in DSM-4, we remember conduct disorder looking like they had to have met criteria for at least one of 4 categories, and they listed those categories: aggression to people and or animals, destruction of property, deceitfulness or theft, severe violation of rules. Well, they've kind of kept those subheadings, but what they said is that they must only meet criteria for 3 of 15. So they specifically put specific symptoms under each category. And if they have 3 of those 15 criteria in 12 months, then they meet criteria. Now, the other piece is that they have to have at least 1 of these symptoms in the past 6 months. So if everything happened 9 months ago and there hasn't been anything in the past 6 months, you cannot diagnose conduct disorder. But if they've had at least one or more symptoms in the past 6 months, and then plus the rest of them later, within a year, then you have conduct disorder. So what are they? So the first category is aggression to people and animals. So specifically under there, they say they often bully or threaten or intimidate others. They often initiate physical fights. They have used a weapon that can cause serious physical harm to others. So a bat, a brick, a broken bottle, a knife, a gun, some sort of weapon that could, seriously harm somebody else. Has been physically cruel to people, has been physically cruel to animals, has stolen while confronting a victim, so mugging, purse snatching, extortion, armed robbery. And then the 7th one under that is has forced someone into sexual activity. So all of that would fall under aggression to people and animals. Now the second section is destruction of property. So with destruction of property, the 2 symptoms that are listed under there, which are 8 and 9, has deliberately engaged in fire setting with the intention of causing serious damage. Now, if you had this on its own, it would be pyromania. So we'll talk about that in a few minutes. But this falls under destruction of property right now, has deliberately engaged in fire setting with the intention of causing serious damage. The 9th symptom has deliberately destroyed other property. And this is by other than fire setting, because the one previous to it is fire setting. The 3rd category is deceitfulness or theft. So symptom 10 would be has broken into someone else's house, building, or car. 11, often lies to obtain goods or favors to avoid obligations. So they're like con artists, or they con others. 12 is has stolen items of non-trivial value without confronting a victim. So shoplifting, but without breaking and entering, or forgery, because that would go into your first category. Now, the last category, which is category 4, is serious violation of rules. Symptom 13 says, often stays out at night despite parental prohibitions, beginning before age 13. So it had to have started before the age of 13. Number 14, has run away from home overnight at least twice while living in the parental or parental's surrogate home, or once without returning for a lengthy period. 15 is often truant from school, beginning before the age of 13. So really, they're looking at 3 of these 15 criteria in the past 12 months. Now, what they're saying is if the person, because now we're on a lifespan, so if the person is 18 years or older, you want to look and make sure they don't meet criteria for antisocial personality disorder, because then if they do, it wouldn't be conduct, it would be antisocial personality disorder. Okay? Now, many people before would say, I know conduct disorder as being like antisocial, and it's kind of a pre-antisocial, which isn't the case, but previously they said you had to meet criteria for conduct before antisocial, and one of those reasons is because of the lack of prosocial emotion. So they often said that conduct kids lacked remorse or guilt, they often lacked empathy, they were unconcerned about their performance. So what they did now is they found that there are kids with conduct disorder that actually do have remorse, that do have empathy, that do sort of have that guilt about what they've done. And so what you would do is, in the instances that they do not, so they have limited prosocial emotions, then you would specify it conduct disorder with limited prosocial emotions. Well, what is the criteria in order to become or have limited prosocial emotions? You must have 2 of the following symptoms persistently in the past 12 months or the past year. 1, lack of remorse or guilt. 2, that callousness, that lack of empathy. 3, they're concerned about performance. Some people ask me, well, what does that mean? Well, they may say, I don't care about this schoolwork. I don't care if I'm getting an F. It means nothing to me. I don't care if I just got fired. So unconcerned about performance and the shallow or deficient affect. So if they have 2 persistently of these 4 symptoms over the past 12 months, at least 2 of these, then you can specify with limited prosocial emotions. So otherwise, if they don't meet this criteria, then it's just a pure conduct disorder, and we know that they're exhibiting these 4 things. They have guilt, they have remorse, they have empathy, they are concerned about their future, they do have some sort of affect. Pyromania. With pyromania, this is deliberate and purposeful fire setting on more than one occasion. And what usually happens with these individuals is that there's some sort of tension or affective arousal before that act happens. They also seem to have a fascination with, or are interested in, or curious about, or attracted to the fire and what happens based on the fire. And of course, you have to rule out fire setting is not done for monetary gain. So some people will burn down buildings, will burn down houses because of insurance purposes. So you have to rule that out, and it's not included in the diagnosis of pyromania. So here, I love showing pictures here. So what else happens with pyromania is that the person has pleasure or gratification, or there's some sort of that tension that they feel is relieved once they set the fires or they witness or participate in the fires. And so here we have a great girl, little girl, she has that affect that's like, don't mess with me. And that's because her neighbor had a bigger teddy than her, and she says, Pat. So she burnt the place down. That's the perception of the picture. That's kind of what happens. So they have some sort of pleasure, gratification, or relief when setting these fires or witnessing or participating in fire setting. Now, kleptomania is the same exact thing. Same exact thing as pyromania, except it has to do with the impulse to steal. So these individuals cannot resist the impulse to steal. It doesn't matter how much money. We've seen celebrities, people who are billionaires, that exhibit kleptomania, and there's just this sense of tension that they have to like steal something, and they get pleasure, they get gratification, or they get relief at the time or thereafter of stealing. And so it's the same thing as pyromania, but it is in fact kleptomania, which is stealing.
Okay, so oppositional defiant disorder. This is characterized by a recurrent pattern of just being angry, irritable, argumentative, and defiant. There's some vindictiveness, but it's really kind of conflict with authority, and it has to have been happening for over 6 months. So could you name a couple other disorders similar? So one would be generalized anxiety. And when you see the oppositional defiant client, you start with your case conceptualization. So what are you going to do there? You want to assess for comorbid disorders, particularly learning disorders, depression, and a history of abuse. So that's your case conceptualization piece. Another thing is ADHD is often comorbid, and this can precede conduct disorder. So you do want to make that differentiation. However, conduct disorders involves a lot more of a serious violation of basic rights. You want to also think about substance use, because there is an increased risk for both anxiety, depression, and substance use here. So what are your goals of treatment? You want to help the patient recognize the inappropriateness of their action. If you said it that way, I don't think you'd get a buy-in from an adolescent, but but also, help them link it to the negative consequences for them. Part of this can be if you're feeling irritable and aggressive, there might not be a lot of coping skills. So you want to teach coping skills like relaxation, assertiveness, anger management. And then they can develop alternatives to the like angry outbursts. Like they have more options for themselves for when that isn't what they would want to choose. If there's any behavior that's antisocial, illegal, cruel toward animals, now that's conduct disorder. Okay, so I'm talking about both, I guess. So you don't need to worry about that. But you do want to help them decrease oppositional behavior. Now, if it were me, some oppositional behavior is very healthy, so I probably wouldn't want to have them get rid of all of it. But yeah, just to remember that this is not the cruel, antisocial, illegal stuff is more the conduct disorder, not oppositional defiant. And it's more like they're losing their temper a lot. They're annoying people purposely, that kind of stuff. Interventions, the interventions for oppositional defiant and conduct are similar. So I'm going to go on and talk about conduct disorder, and then you'll hear more about the interventions then. So conduct disorder, know that conduct disorder means you have 3 symptoms from 4 categories, including aggression, destruction of property, deceitfulness, and serious violation of the rules. The duration needs to have been over a year and included 3 or more of the symptoms. The onset is during childhood. You can't diagnose it after 18 if they meet the criteria for antisocial. Often comorbid with ADHD, ODD, learning disorders, depressive, bipolar, anxiety, and substance disorders. The interventions are multiple, but the first thing to remember is family and actually multi-systemic. So it's really useful, especially for youth and adolescents, to have out-of-home placement if they've been at risk, and just a lot of support, academic, social skills. This is really something that needs to happen on all fronts. Parents need to be trained to replace any sort of coercive or negative inconsistent discipline, and that is functional family therapy is often used to help with those interactions, starting with engagement, behavior change, and then generalization finally. In terms of the patient themselves, cognitive problem-solving skills training help them figure out new ways to solve their problems versus just going to violence. And then pharmacotherapy is not generally recommended. However, that can be used if the behavioral problems are escalating and they're really posing a risk of danger. If this person wants to change and they can't, or they have ADHD, it might be useful. And then the final thing that we just mentioned briefly is sometimes out-of-home placement is really important. Because if there's severe family dysfunction, it's really not going to work. And you can see homicidality and suicidality sometimes too.
To do is meet 2 of 10 criteria over a period of 12 months, and they meet that, whatever the drug or alcohol, whatever it is, use disorder. Now,
okay, we're going to talk about substance-related and addictive disorders. So what is substance use disorder? This has been a change from the DSM-4. When you want to diagnose substance use, you need to have 2 or more symptoms that have gone for 12 or more months. And they happen in a cluster of cognitive, behavioral, and physiological categories. But what the crux of it is the person's continuing to use a substance despite significant problems. You can specify here whether it's in remission, early, sustained, or if they're in a controlled environment. So maybe they're not drinking, but it's also because they're at a facility, and the level of severity. There are different symptoms that have to do with how much control the person has, their social impairment, any risky use, and then the pharmacological piece of like tolerance, withdrawal, and cravings. So we're going to talk more about the treatment, but let's do the really quick overview here that first you want to use motivational interviewing and motivational enhancement therapy to increase the actual desire to address the issue, because that's not always there. You want to think about contingency management and multidimensional family therapy. And then finally, you need to, as you have made some progress, you need to think about skills training and relapse prevention so that they have skills where they don't need to go to the substance to deal with their anxiety or whatever it might be that is stressful for them. Medication management can help, because there can be symptoms that were being masked by the substance use. What referrals would you want to make? 12-step programs. The test is positive toward those. And medical evaluation treatment, of course, psychiatrist, or medical and psychiatric evaluations. And then you need to think about neuropsychology because of damage that could be done over time with severe substance use problems. Inpatient, and then you need to decide, you don't decide, but thinking inpatient detox, long-term residential, sober living home, what is going to be the best context to deal with this? Vocational rehab, a lot of just destruction can be brought onto one's life. So using social services and vocational rehab to kind of rebuild is also useful. So substance-induced disorder, basically, it's another disorder. It's a clinically symptomatic presentation of a mental disorder, but it developed within a month of a substance use withdrawal, and you really can't explain it any other way. So delirium, we already know, is a result of withdrawal. So we're not talking about that, but it could be other things. And there needs to have been intoxication and or withdrawal to actually make this diagnosis. What's the duration onset? Well, in general, it needs to be within 1 month of the intoxication withdrawal. For alcohol-induced, the withdrawal is going to happen within a few days. and 2 or more symptoms within a few days of reduction, and you have a substance-induced. And tobacco withdrawal symptoms happen within 24 hours. 4+ symptoms within 24 hours is the criteria here.
Cognitive disorders. And so, cognitive disorder. And so, what they say to be defined is the following. So, you need to define and look for a significant decline in one or more cognitive domains. And those cognitive domains are really well listed in Table 1 of the Neurocognitive Disorder section of the DSM-5. The first one is complex attention. So, complex attention, the decline here for major versus mild. So, major would be has increased difficulty environments with multiple stimuli. So, the TV's on, the radio's on, there's a conversation going on, and they have an increased difficulty in those types of environments. They're easily distracted by competing events in the environment. They're unable to attend unless input is restricted and simplified. So they really, really have a difficult time holding new information, such as recalling phone numbers or addresses or reporting what was just said. And so you'll see that as a major, under complex attention, that is a major neurocognitive disorder classification. Mild, on the other hand, for complex attention, would be normal tasks take longer than previously done, begins to find errors in routine tasks, finds work needs more double checking than previously. Thinking is easier when not competing with other things such as the radio, TV, other conversations, the cell phone. And so they look at that as a mild cognitive disorder in regards to complex attention. So the problem here is that a lot of this is normal aging. And that is one of the controversies about this section, because they're saying, all right, this is normal aging. Why are we calling it a disorder? And so it is what it is. It is that. So executive functioning, deficits in executive functioning for anybody, we're going to be looking at, whether mild or major, we're going to be able to look at their planning. So how are they able to interpret object arrangement or to find an exit of a maze? Decision making, looking at performance tasks, and a lot of this parallels with a lot of those intelligent tests and cognitive tests. Working memory. So what working memory is the ability to manipulate data. So if I give you 5 numbers and I say 1, 5, 2, 4, 6, and I ask you, repeat that back to me, that's using your primary memory. If I say, repeat that backwards, that's using your working memory. So we're going to assess that in executive functioning. So those are some examples, not all of them, but some examples of executive functioning. Well, let's look at learning and memory. So what does their immediate memory span look like? What does recent versus remote memory look like? And then within that, we'll look at mild versus major. So it does a really good job of giving you examples within the DSM, like I said on the table 1 listed in neurocognitive disorders. Perceptual motor is another one we want to look at. So what does their visual perception look like? Can they see bisections of tasks? Also, you want to look for, have they integrated learned movements? So, for example, saying goodbye, waving goodbye, are they able to do that? Saying things like, can you command them to say something? So use the command, show me how you would use a pen. Can they do it? If not, that's a decline. If they didn't previously have that, that is a decline in perceptual motor. So that would count for either mild or major. So you'd have to look that up. Language would be things like expressive language, grammar and syntax, receptive or comprehension, language. So that would fall under language. Lastly is social cognition. So are they able to recognize their emotions? Are they able to understand why? So if you show a picture of somebody who appears sad, are they able to say why? Are they able to know that the person is sad? So this is the ability to understand social recognition of emotions as well. So that's what we're looking at when we are looking at the decline. So they could have one area that is of significant decline, but they have to have one or more in order for it to be a major or mild neurocognitive disorder. Now, what you have to do is specify whether it is due to Alzheimer's disease. So what they did is they got rid of the terms dementia, and they're having you specify, is this neurocognitive disorder due to Alzheimer's disease, Lewy body disease, HIV infection, prion disease, Parkinson's, Huntington's? They're asking you to specify that specifically so they know what is this neurocognitive decline due to. And so you would look those up and see what may pertain to the client. Now, conditions for further study. So we're almost at the end of our lecture.
So delirium requires two things. The first is a disturbance in awareness, and the second is a cognitive disturbance. So the disturbance in awareness can arise in a very short period, and there's a lot of fluctuation. The cognitive disturbance means that there's memory, orientation, language, perceptual, visuospatial, that there's just this general confusion. And the treatment here is to figure out whatever it was causing it. So if it's withdrawal, you need to treat whatever the cause of the delirium is. But the way of kind of handling it in the moment is to reduce the agitation involved by a really caring environment and antipsychotics. How do you tell the difference between delirium and dementia? Delirium is abrupt, dementia is prolonged. So there are major and mild neurocognitive disorder, and this is about how severe it is. There's evidence of significant decline from functioning that interferes with independence and doesn't occur in the context of delirium for major neurocognitive disorder. For mild, there's modest decline in functioning, and they can still be independent, even if they're compensating. The DSM-5 identifies 13 different types based on their etiology. We're going to talk a little bit more about 3 different kinds, the Alzheimer's, vascular, and HIV disease types. But there can be other causes like Huntington's, Parkinson's, traumatic brain injury, etc. Okay, so we'll go a little deeper into this in a minute, but for neurocognitive disorder due to Alzheimer's, you want to look at declines in cognitive functioning and declines in ability to carry out basic daily life tasks. So when you're in the minor area, you're still able to be independent. There's a modest decline in cognitive domains, some maybe difficulty with memory, but still functioning independently. Once it's major, it's a significant decline, and it's really interfering in multiple ways. The onset with Alzheimer's disease is insidious and gradual. It's slow, it's progressive. Some days are better, some days are worse. So it can be unclear even to, caregivers, friends, family members, what's exactly happening. Because some days they seem fine, but it's progressive. There's 3 stages: stage 1, stage 2, and stage 3. Unlike vascular dementia, or neurocognitive with vascular cause, this is long and drawn out, which isn't, there can still be good in life and love and family and all of that, of course, but it's a long process. So stage 1 is the first 3 years. So there's some irritability and there's some change in mood, right? There's more sadness, more indifference, and there's some starting to be
difficulty with interrograde amnesia. So basically, like, it's hard to kind of remember, like, where did I put my keys, or what did I do yesterday? Like, there's trouble forming new memories. And you might notice a little visuospatial disorientation. Stage 2 happens in the next 10 years. And that's when retrograde amnesia, the past starts to go. Mood becomes more labile, more flat, more agitated. And then you start to get things that are a little bit more representative of a kind of purely or more pure cognitive decline, with aphasias, acalculias, apraxias. And then finally, 8 to 12 years when you start to see the severe case. And this is really deteriorated functioning to the point of, sometimes not able to talk, limb rigidity, incontinence. So those are the 3 stages. So what does it look like with Alzheimer's disease? Here you have a really insidious onset of symptoms and a gradual progression. There's 4, or not 4, Bella is dreaming. There are 3 stages here, starting from the first 3 years, the next 10 years, within the next 10 years, and then 8 to 12 years. The first 3 years, hard to form new memories, and there's some visuospatial stuff and irritability. But as you get deeper into it, retrograde amnesia begins, and the mood starts to flatten, and there are language and kind of more problematic things. And then finally, once you get on the average about the 10-year mark, there is really severe deterioration that occurs to the point of incontinence and really not functioning anymore. There's a genetic component here. The early onset is associated with chromosomes 1, 14, and 21, but there is different chromosomal piece. Acetylcholine is the associated neurotransmitter, and the brain area is the medial temporal area. In particular, the hippocampus and amygdala are impacted, as you can imagine, because of the emotional issues and the memory issues. You can get this disorder if the criteria for probable Alzheimer's has been met. And 60 to 90% of people with dementia actually have Alzheimer's disease, so it's the main cause. Vascular episodes can also cause neurocognitive problems. Diagnosis, there was a past cerebral vascular disease. With this, unlike Alzheimer's, which is insidious, there is an acute onset. Well, there's 3 different ways. There's acute onset where there's partial recovery, there's stepwise decline, and then there's progressive that, it fluctuates in terms of how much concentration, memory, and psychomotor speed there is. Neurocognitive disorder due to HIV infection. The HIV is the source of the problem, and it causes subcortical area damage. There are considered to be 6 stages from 0 to 4 end stage, where you progress from normal to the point of vegetative and incontinent. Impairment of concentration, memory. There's depression and tremors here. And lastly, we'll talk about personality disorders. 3 clusters. Cluster A are the odd and eccentric. Cluster B are the dramatic, emotional, and erratic, and cluster C is the anxious and fearful. So the mnemonic you can use to remember is we've got A, B, and C. So A is for abnormal and awkward. There's a little picture of Elmo on the slides here. B is for borderline and buzzing. So those are the dramatic, erratic types. And C is for cautious and careful. And just to note that though avoidant folks can be a little bit awkward, and it does start with an A, it is much more about being cautious and careful and anxious. So A is more the schizoid, schizotypal, kind of eccentric, odd. And B, the borderline and buzzing, is your narcissism, histrionic, antisocial, etc. So let's talk about just a summary
overall of all the personality disorders. So the diagnostic criteria is going to be an enduring pattern of inner experience that deviates markedly from cultural expectations. There are symptoms in 2 or more areas: cognition, so how one thinks, affect, the emotional states and experience; interpersonal functioning, it's really prominent there and obvious there; and then impulse control. What's characteristic of these disorders is that they're pervasive and inflexible. So on the CPSE, if you have an explanation of a client or a vignette where something's been chronic and you see it at home and at work and it seems like it's gone back years, especially if there's kind of an interpersonal aspect to it, like getting fired from jobs and breakups, then it's important to consider at the very least personality disorders. The onset is typically early adolescence or adulthood, and with antisocial, for example, though, it has to be before 15 that the onset happened. That said, you cannot diagnose it until after they're 18 years old. So often they will be diagnosed with oppositional, defiant, or conduct disorder beforehand. With narcissism, you'll see it also typically begins in early adulthood. And just some specifiers, you note the clusters. We talked about the clusters, so note whether it's A, B, or C, and C for your second to yourself if you can just name the types in the different clusters and what the clusters are all about. There are 3 types in A, 3 types in C, and then the middle of the sandwich, B, has 4 different types. So see if you can think of those. Paranoid and dependent aren't discussed as often as some of the other ones, but paranoid's in cluster A and dependent is in cluster C, as you can imagine, with them being very anxious. So the best treatments overall, and we'll talk a little more in particular about borderline antisocial, but just here's the key points, is that for borderline personality disorder, you want to think DBT, and in general, short-term and skills-focused therapy can help improve psychosocial functioning, among other things. Referrals that you want to think about in personality disorders, in some cases, psychiatric medication doesn't help because it's more of a personality thing, but with borderline, for example, sometimes mood stabilizers, or maybe SSRIs. There could be coexisting conditions, both as a result and tied to it. Especially because there's definitely some theories, this probably isn't on the test, and maybe don't even think of it as on the test, but there's definitely a theory that it's really, borderline is just attachment trauma. So make that referral for the evaluation. And other important referrals to make, 2 things. Self-help groups can be helpful because it's so pervasive. There needs to be really continuous care and community. It's similar to substance abuse problems and alcoholism. There, especially with something like borderline, and not for schizoid and other ones, but given the sort of more ingrained nature of it, it's important that they have support more frequently than just once a week, at least when they are kind of more in the throes of things. Inpatient hospitalizations are helpful in terms of stabilizing acute episodes, in particular with something like borderline personality disorder, which we will talk more about in a moment. There are new culture-related diagnostic issues, like with schizotypal, voodoo, or antisocial is overdiagnosed with lower SES. Okay, so now we're going to do a very quick rundown of the 10 personality disorders and how many are in cluster A, which is, and how many are in cluster B, which is, and how many are in cluster C, and what is cluster C. So answer that for yourself. And now I'm going to begin to go through them, starting with cluster A, which, as you probably just named, is the odd and eccentric presentation, and what's your mnemonic? Abnormal and awkward. The 3 here are paranoid, schizoid, and schizotypal. So schizoid and schizotypal sound similar, easy to remember those 2, and since there's only a third, paranoid, if you can remember it exists, clearly that's going to be your more odd and eccentric one. What does that look like?
This looks like a pervasive distrust and suspiciousness of others, and this tendency to interpret actions of others as deliberately demeaning, threatening, malevolent. You've probably met to some degree people of this type. Maybe they're not fully have the disorder, but in your life, people who kind of just always are attributing others to, like, oh, they're out to get me, at work. Like a colleague does something, sends an email with that maybe is a little bit short, and it's like, they're trying to get me fired, da-da-da-da-da. They suspect, so here you need to have, and this can be a little bit difficult to remember, but a lot of times with the personality disorders, there is 4 or 5 symptoms needed. So with paranoid, you need 4, and among those are suspecting exploitation, people are harming them, they're preoccupied with doubts about trust, they're reluctant to confide, they're afraid people will use things against them. Benign things become threatening, grudges, perceiving attacks, counterattacks, and also you would imagine maybe believing their partner is unfaithful. I will say, when I read this one sentence that says interprets benign comments and events as demeaning or threatening, I think one way to really, as a clinician, and this is kind of my interjection, to be A, most helpful, and B, actually probably more in line with reality, is to acknowledge that there's always something little. And yes, you probably want to explore, who knows, maybe something happened in their childhood where they really couldn't trust. So a lot of the reality might be more about that, and you can help them tie it back to the original event if you have that kind of orientation. But, I think just saying, they're just interpreting benign comments as threatening, can be somewhat of countertransference on all of our parts, because it's really not fun to be around someone who's always angry and counterattacking, even when you really are coming from a pretty much benign place. They're still reading things that are somewhere deep under the surface, maybe even if it's just a 100th sliver of reality. And then, of course, they end up creating some of these things, like we all do with our expectations. So that was a lot on paranoid. Maybe it's deserving of a little more time, because I have not found it's discussed as much. So what about schizoid? Schizoid is a pattern of detachment from and indifference to social relationships. There's like a restricted range of affect. Here you also have the 4 symptoms, not enjoying closeness, being solitary, not interested in sex, little pleasure, no close friends, indifferent to praise, cold, detached, flat. Okay, and so this type, they don't really care much, right? So with avoidant, you might find they're also really super loners, but they feel longing and sensitivity and hurt when thinking about fear of rejection. With schizoid, there's much more of an indifference, and you're not going to find these people in treatment very often, because maybe you do, but this isn't actually a problem for them, even if we might have a problem with it, if it's someone in our life that is a family member or someone we want more closeness with. Schizotypal, this is the type that is connected to schizophrenia, and first cousins, there's a higher chance that you'll see schizophrenia. So what would you say? How would you describe it if you had only 5 words? It is a pattern of blank. Deficits in social and interpersonal functioning. I guess we should actually add more than 5 words, because that's true in a lot of the personality disorders. But what is it marked by? Reduced capacity for closeness, and then peculiarities. So the peculiarities happen kind of in all aspects of being, whether it's cognition, perception, ideation, appearance, and behavior. So these are your folks who are odd, Honestly, I think that schizotypal folks can be the most fun ever. Now, of course, if there's a lot of, maybe that's not, of course, if there's a lot of suspiciousness and paranoia, that can be problematic for relationships, but, they might have odd beliefs like telepathy and clairvoyance, so maybe that's part of why I can relate.
unusual perceptual experiences, odd thinking and speech, lack of close friends, social anxiety with paranoid features. So you can see the strong tie to schizophrenia. But I think maybe in all of these cases we should appreciate the interestingness and difference of people, and that there are good things that come along with all of this. Okay, that's a statement to unpack and discuss, so you can have that conversation after the test. So cluster B, what's the mnemonic for it? Or your own, if it's not the same. Bizarre and buzzing. So buzzing I say because you can sometimes have, like with the narcissism, there's kind of like bigness, and with the histrionic, excessive emotionality. So that's kind of what I mean by buzzing. It's the only B word I could come up with. Now borderline, you could also think borderline and buzzing, because borderline is also in here. So let's start with antisocial. If you think dramatic, emotional, and erratic, to me, I really do end up picturing borderline when I think of dramatic, emotional, and erratic. That said, if you have someone committing unlawful acts, lying, having physical assaults, you got to think physical assaults, that's erratic. Disregarding safety, irresponsibility, not remorse. So yeah, in some ways there's not the same kind of emotionality. In some ways there's a lack of emotion, but you still want to think that they're, in terms of anger and the physical fights and assaults, even if there is a flatness and a lack of empathy, there's still, you'd have to talk to an expert in antisocial, but the assaults and the kind of viciousness that can happen, there's something there that is on that emotional or repressed emotion line. And what do you want to remember in terms of age of onset and when you can diagnose it? That's really important to think about. It needs to be, there needs to be evidence of it of conduct disorder, that is, before age 15. And before you can get the diagnosis, you need to be 18 years old, which I think is very fair, because it's a pretty serious diagnosis, and one of those that's viewed as quite intractable, similar to borderline. But I have another comment on that. So borderline is the next one we're going to talk about. So antisocial and borderline are frequently discussed, though narcissistic is too. But borderline, antisocial you might end up seeing in prison settings. They get in trouble with the law. Borderline you might see more an inpatient with the recurrent suicidality. Whereas narcissism, perhaps we talk about it in terms of providing individual therapy, because you see that, but in terms of sort of the extreme situations, there's not as often the sort of physical danger that you see with antisocial and borderline, though from different places. So what is borderline? You really want to, if you see a question or a client where you're seeing really unstable interpersonal relationships, you want to consider this diagnosis. We all have these tendencies. Every single one of these things we have in each of us, and under stress, we all have our tendencies of where we go. So don't necessarily diagnose someone as fully with the disorder, because it can come with a lot of stigma. But you also do want to catch it so that you can really tailor treatment and help people the most. And we really should stop pathologizing people as much as possible in general, because it undermines treatment. So borderline, there is real instability of mood, instability of interpersonal relationships, self-image, and a lot of impulsivity. And here you want to see 5 or more symptoms. So along the lines of abandonment, unstable relationships, idealizing, impulsivity. It could be with spending, sex, substance abuse, recurrent suicidal or self-mutilating behavior, emptiness, anger, and dissociation. So all of that. Some people think of borderline as attachment trauma. And in terms of onset and diagnosing, while it's viewed as very intractable, there is also evidence that says that after that you see it in the 20s and 30s, but it tends to kind of disappear or the prevalence goes down after 40. So I think there's actually a lot more hope than is given credit for. We're going to speed through the rest just for the sake of time.
But histrionic. So features of histrionic, this is the one that is just about excessive emotionality and attention seeking. Yes, borderline and histrionic could look the same, but they're really not, because there's a kind of shallowness to emotion. It's really about being the center of attention. Considers people closer than they are, and there's just a rapidly shifting emotions. 5 or more symptoms here. Narcissistic, 5 or more symptoms. So you see, I think, with most of the cluster B, it's 5 or more. Narcissistic, grandiosity, fantasies of greatness, belief in being special, need for admiration, entitlement, exploitative, lacking empathy, envious, arrogant. Cluster C, these are the anxious and fearful ones, and there's 3 of them. Can you name them? Okay, so OCPD, that's the obsessive compulsive, so you can think that's very anxious and fearful. That's probably a pretty easy one to think of, but there's also avoidant and dependent. Avoidant is a pattern of social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation, with 4 or more symptoms. Fear of criticism, disapproval, won't get involved because they're not certain they'll be liked, restrained in intimate relationships, preoccupied with rejection, just a basic sense of inferiority and inhibition. Dependent is a pervasive and excessive need to be taken care of, and what it results in is submissive and clinging behavior. It's just hard to do much of anything without somebody else, like can't make a decision without reassurance, don't want to assume responsibility for things. They'll go along, they're terrified of losing your approval, and they'll really do much of anything to get support from others. When they're alone, they just don't feel like they're self-sufficient and will seek new relationships when one ends with fear of being alone. A little different than the borderline sense of emptiness and impulsivity, but there is still the sense of there is a sense of it will be dangerous if someone leaves. So that's a similarity, but it is different. Obsessive compulsive. This is not obsessive compulsive disorder, it's personality disorder. So this is more just, if you picture, maybe they should even give it a different name. This is really about someone who's very inflexible and can be very inefficient because there is a way they want to do things. There are details, rules, schedules. Sometimes the point of why you're doing it gets lost in the way that things are supposed to be done. There is just order, perfection, control, a drive toward that. That trumps whatever else the activity is. It's about how that activity is done in the perfect way, which then it gets in the way of actually completing things, and there tends to be more of a focus on work and a drive toward being, the perfection, moral, and difficult then to discard things and delegate. They can be stingy with money, rigid and stubborn. And what I would say here, and then I guess what I'd say here is that can lead to a lack of friendship and fun in life. Okay, so those are the personality disorders, and we are going to have a lot of fun now in talking about the treatment of personality disorders.